All right, Dr. Bronson, thanks for joining us today. And you are
Well,
representing your business, your clinic, B3 Clinic, correct?
E3 Clinic, that is correct. In
Awesome, my
good old
man.
Huron and Sioux Falls, South Dakota.
Would you mind tell us a little bit about yourself, what you do, your history, your background, and kind of how you
Sure.
got into the TRT world?
Well, since 2017, when I was a internal medicine resident at Mizzou, I've been interested early on and mostly in synthetic androgens and research related to that. So I did a few things as a resident learning about testosterone and the risk reduction management of men on synthetic androgens. And then when I got out of residency in 2020, I started devoting part of my primary care practice to, just testosterone replacement. I was also a hospitalist at the time. So I was one of those old school doctors that I was in a rural area. So I was seeing patients in the hospital and the clinic. Anytime my patients went to the hospital and had to be admitted, no matter what time or day it was, I had to go in and, admit them.
You had to do
And
rounds on them and all that?
and do rounds on them and everything. I get called at all hours of the night about them. And then we kind of switched more to a hospitalist model, part-time outpatient model. Um, and I've been doing TRT, the entire time. Now in 2023, coinciding with a kind of a really brutal divorce situation I went through, I opened my own business and have been doing mostly men's health, TRT, and I've been doing a lot of women's health too. I'm a member of the North American Menopause Society.
The names? Yeah, yeah.
So yep. So I do post and perimenopausal HRT for women as well. And that's kind of been a full-time thing for me since 2023. And then lately, we've been doing kind of expanding out. We had a brick and mortar clinic out in Sioux Falls, South Dakota. It was very, very successful. And then we're looking to start expanding into places like Florida. And the next big stop, I think, for me is going to be Omaha, Nebraska. So, it's been highly rewarding. The other thing that I've been doing ever since I stopped being a full-time hospitalist is a lot of research on testosterone. So I'm an adjunct faculty member at the University of South Dakota School of Medicine. And the real secret benefit when you're a physician is that if you become a faculty member at a med school, they give you access to their library. And
Oh,
that means you have electronic access to all kinds, like millions of dollars worth of journal subscriptions,
sure.
just electronically. And that's when I really started to dive into the latest research on testosterone, hormone replacement, doing a lot of checking and fact checking a lot of the dogmas that we practice by, you
Sure.
know, the, things like testosterone is bad, causes all variety of heart problems, may cause cancer, things like that, which those aren't as strongly held dogmatic beliefs anymore, as because they're wrong and they've been proven wrong. But also, even latest, my big project for the last, I don't know, about year has been estradiol in men and how a major benefit of testosterone therapy, medical testosterone therapy, is the fact that you get an estradiol response. And so when your
Hmm.
estradiol level goes up, what effect does that have on the benefits of TRT as a whole? Usually, 90% of providers think that estradiol levels rising is a like side effect to be combated. But we know now from, very, very, very good research that estradiol going up is one of the main benefits of
Sure.
TRT.
An expected response.
Specifically, the biggest benefit that you get from a rising estradiol level is that it reduces your visceral fat. So one kind of way that I practice, which is very different from most, I don't know if you want to call us TRT providers, um, if that's an acceptable term, don't want to insult anyone. um, you know, is that I rely very, very heavily on body composition scans. My average patient is 40, 50, 60s, sometimes even older, sometimes slightly younger than that. But
Yeah,
the
yeah.
vast majority of them are at least overweight or obese and have metabolic syndrome, including
Hmm.
type 2 diabetes. And so when I look at their body composition scan, that tells me a lot about whether they can benefit from testosterone or not. Really more so than their baseline testosterone levels, because ultimately what testosterone does is body recomposition, right? So you build muscle, you lose fat, and obviously there's a lot of evidence that you gain bone density
Hmm.
um, as well, which that's another story. But, those are the exact opposite effects of what you get with very serious chronic diseases like chronic kidney disease, diabetes, or even aging itself.
Sure.
One of the natural just processes of inflammation that comes with aging, and in the research literature, it's called inflammaging, is that you get an increase in body fat and a decrease in skeletal muscle. But most importantly, you don't just get an increase in subcutaneous fat, you get an increase in visceral fat. So visceral fat would be the fat that surrounds your internal organs, that lines the omentum, that secretes very pro-inflammatory adipocytokines directly into the portal circulation of the liver. And anytime you hear the term obesity related illness, and you hear that obesity increases your risk for cancer, it increases your risk for diabetes, etc., that's all due to visceral fat. That's not due to subcutaneous fat. So visceral fat is the thing that is bad about your overall fat mass. And we've known since 2016 for sure that testosterone therapy reduces visceral fat.
Sure.
And
Absolutely.
then just in the last few years, we've discovered, how does testosterone reduce visceral fat? Well, it's an estradiol thing. It's not really a testosterone thing. So when men are on testosterone therapy for a year and their estradiol levels rise while they're on testosterone, they start to lose visceral fat. And that's when you really get the longevity benefits. If it's ever shown, which I firmly believe with all my heart, it will be shown in the long term that testosterone therapy in most men reduces all-cause mortality. We already know
Absolutely, man.
it improves quality of life, but I do believe we eventually will have very good long-term evidence that it reduces all-cause mortality in the same way that estrogen replacement therapy in postmenopausal women reduces all-cause
Hmm.
mortality. The main reason why that would be the estradiol effect, the decrease in visceral fat, which is an estradiol mediated process. Another thing that I discovered about a year ago, which was very shocking to me, it shouldn't have been, but it was, is the fact that there are certain researchers, like a lot of research is siloed in the United States. Like they're molecular physiologists, molecular biologists who are on the cutting edge of doing research on androgens and androgen effects on different cell types. And a lot of that research doesn't percolate to the clinical people for
Sure.
sometimes decades. So they will discover things that a lot of, just they're more like what we would call bench researchers doing mechanistic studies. And a lot of their research doesn't percolate to the more clinical people for sometimes it's a lag time of, like I said, 10, 15 years. And stuff started coming out about the role of estradiol, not only in the fat remodeling process, but also in the um, endothelial protection process.
Hmm.
So it
Yeah,
turns
for
out
sure.
that androgen, and this is something that I talk about with, because I told you I have a cohort of synthetic androgen users as my patients that I see, and it's mostly my practice with them is risk reduction. But these researchers that I'm talking about have noticed that androgens, testosterone, obviously being the main endogenous one, they tend to cause a pro-oxidant state in cells that line blood vessels and in certain types of heart muscle cells. And the way that that is counterbalanced naturally in the body is the local conversion of testosterone to estradiol.
Hmm.
So
Hmm.
I've shown on my live streams, shown in at least one video, and definitely in an interview that I did about 3, 4 weeks ago on the anabolic doc, that the paper that shows the diagram where you have testosterone that increases the pro-oxidant state, can cause mitochondrial damage if it's unopposed. And the thing that directly counteracts the local effects of testosterone on those cells is estradiol. It does the
Yeah.
exact opposite thing. So that to me is when I started saying, wow, not only does estradiol have proven benefits with just regular medical testosterone replacement, you actually need your estradiol levels to rise with your testosterone levels, because that's how you balance certain inflammation in certain cell types.
Hmm.
So this has led to my latest hypothesis that the reason why we see a lot of these young synthetic androgen users die earlier than their pre-1990s counterparts is that, the pre-1990s guys, and I don't know how much you want to talk about, PED use and stuff, so I'll make this quick. But the pre-1990s guys had to use very high amounts of testosterone, and they didn't have drugs like an anastrozole. Arimidex, came on the market in the mid-1990s as a treatment for estrogen receptor positive breast cancer in women. And it was quickly adopted by bodybuilders because, it allowed them to manipulate their estradiol levels. But I think that's a big reason. The fact that we know that unopposed testosterone can cause vascular damage. It's really unopposed, androgens in general. And the way that that's balanced is with estradiol. So you have a lot of young PED users today using very high amounts of non-aromatizable, meaning compounds that do not convert to estrogen,
Sure.
relatively lower amounts of testosterone, so lower amounts of aromatizable androgens. And on top of that, they're using a lot of AIs. And so I think this is what explains why you see these guys drop dead in their 30s and 40s from massive MIs. And, some of them blow out aneurysms. It's crazy. They have accelerated plaque deposition, and a lot of them have, widow makers in their 30s and 40s.
Yeah.
I
Yeah.
think the estradiol story has a lot to do with it. Now, obviously I don't have proof of that. That's just a working hypothesis, but it is interesting when you look at some of the basic, mechanistic biochemistry studies being done on testosterone and estradiol and how it may relate to the things that we observe in clinical practice today. So when I have patients on testosterone, number one, the big key thing is what's happening to your body composition. Well, even before I put them on testosterone, I want to know, what is your body composition like? Do you have a lot of visceral fat? Do you have low amounts of skeletal muscle mass? The perfect patient for testosterone, in my opinion, is not necessarily the guy who has two early morning fasting levels of 250. Okay.
That's pretty
Um,
flawed anyway. We kind of know
yeah,
that.
it is very
Kind of.
flawed. But the perfect patient for me is not just some otherwise healthy 40-year-old with levels that are, slightly below the lower limit of normal. And that's the guy that definitely we're going to benefit from testosterone. No, the guys that I think benefit the most from testosterone are the ones who, regardless of their initial total testosterone level, are obese, have metabolic syndrome,
Yep.
and
Sure.
and potentially many other symptoms of what I would call functional hypogonadism, if not, they don't have true, meet the levels criteria, whatever. Those guys benefit the most. And I have dozens and dozens and dozens of examples of, putting those guys on testosterone and seeing their body composition change. Now, in the case of patients who are obese, and especially those who have diabetes, I mean, obviously, they're on diabetes medicines. The GLP-1 drugs,
Yep.
Ozempic, Mounjaro, stuff like that. Those drugs work great. So those drugs can be used in those guys, but you add testosterone to that, it's like very, very powerful, very, very effective, because as they lose weight, they preserve their muscle mass. So to me, I'm a body recomposition doctor. I'm not strictly speaking a testosterone doctor. I'm all about body composition. I want to know how
Yeah.
your body composition changes. And the labs that I follow and look at more closely then testosterone levels, estradiol levels are what's happening to your lipids over time, what's happening to your A1C over time, potentially even some of your inflammatory markers, things like that. And at the end of the day, I'm an internist. I'm a board certified internist,
Sure.
so
You
I
like to dig
still,
deep.
yeah, I still just monitor people's, the usual stuff. Treat the hyperglycemia, treat the dyslipidemia, all that stuff. But testosterone is such a useful adjunct at achieving body recomposition that it tends to make all those things significantly better in the long term.
What would it be like for, let's say, well, it's hard to say a quote unquote typical, but what would be like an onboarding or evaluation or a workup like? What are some of the diagnostics and things that you would incorporate into that?
So the first thing that we do when patients contact us is, or like before they come see us, is we send them a very long intake form that asks about all their symptoms. Some of them are potentially androgen deficiency related. Some of them are, just other lifestyle things, their eating habits, sleep habits, things like that. But I also have every patient get a body composition scan, at least an in-body 570 scan, which is a
Okay.
non-invasive like impedance
Sure.
thing, because I don't just want to know your BMI. I want to know what your body fat percentage is, and I want to get some measure of your visceral fat. Because if you have a lot of body fat, you have low amounts of skeletal muscle mass, and bonus, if you have a lot of visceral fat, boom, that's something testosterone can absolutely help. And that's something that, you know, definitely those guys get, in many cases, really life-changing results from testosterone.
Absolutely.
But, we see it all the time. Oh, these guys who are massively overweight go into their primary care doctors and they're like, can I have my testosterone levels checked? And a lot of times primary care doctors don't realize that obesity and metabolic syndrome, those are actually symptoms of hypoandrogenism.
Sure.
Well,
Sure.
whether it's absolute biochemical or whether it's just, functional. And so, I mean, we can get into talking about how imperfect testosterone testing is and why it is absurdly over relied upon in both guidelines and just clinical practice in most primary care offices. But for me, those are the two key things is I want to know all about your symptoms and I want to know what your body composition is. And in fact, I'll tell you, if I know what the body composition is in detail, I typically can predict what the labs look like, especially once someone's on treatment. So for me, body composition is everything. It's definitely mandatory.
Sure. For sure. So when it comes to risk reduction, those types of patients, are there other diagnostics, interventions you would do for them versus like, let's say, the metabolic syndrome patient or the fatty liver patient who comes for TRT? How do
Oh
you approach
yeah,
that
yeah.
differently?
So, yeah, so the patients that come for TRT are obviously they're very, very, very different from the patients who are like anabolic steroid users. And in my treatment approach in patients who are just call them synthetic androgen users is really it's more very advanced internal medicine and preventative medicine. So there's a lot of misinformation about steroids out there. Usually the mainstream, medical establishment is just like steroids will kill everybody who takes them. They're extraordinarily dangerous. Never touch any kind of steroids. Never use over 200 milligrams a week of testosterone, you know, um, or you'll die type of thing. And then there's also in the PED community this misconception that they're just all safe. And all we know guys who've been on them for decades and they never have any problems. Well, I have dozens of examples of people on PEDs that have caused very, very severe damage, irreversible damage to their health. So there's fear mongering on one side and a total lack of knowledge by primary care doctors how to take care of these guys on one side. And then you have on the other side a lot of PED users that try to be their own doctor, which really just translates to they don't, really monitor their health and understand the full effects of the compounds they're on. on things like their kidney function, their, you know, ability to accumulate plaque in their arteries, and even on, you know, various, you know, mental mood states. So my role is to know and learn as much about the compounds as possible, and to take these guys who often have to be on these compounds for, I don't want to say lifestyle reasons, but to just put it simply, a lot of them are on steroids because their livelihoods depend on it.
Yeah.
So, you know, they have to, so they have to be on the compounds. They're going to be on the compounds no matter what the doctor says to them. And so my role is really just how do we minimize risk the most? So I use a lot of testing in those guys. I do coronary artery calcium scans on
Sure.
them.
Sure. For sure.
Even if they're very young, I have patients in their 20s that have significant amounts of plaque, which is, you know, shocking to them almost all the time. I have guys with very profound kidney dysfunction that, you know, we need to have come to Jesus discussions about their continued PED use, whether they want to be on dialysis or not. The majority of my patients, though, it's really just about monitoring the things that matter, making sure that their LDL is below the 5th percentile, so below 70 if they're
70.
on
Sure.
synthetic androgens, making sure their ApoB is under, you know, 50, 55, and, you know, making sure that their blood pressure is well controlled. A lot of synthetic androgens, this is something that I recently have popularized because I've never heard it done by any other doctors before, is but the regular use of 24-hour ambulatory blood pressure monitoring
Yeah.
in patients using 17 alpha alkylated steroids, which cause profound mineralocorticoid effects. So you have guys with normal blood pressure during the day who have skyrocketing blood pressure at night.
Saying
And
supine is it spikes.
yep, supine,
Gotcha.
profound supine hypertension. And so I've started detecting that and treating those guys appropriately. And I think a lot of them, you know, especially the ones that are going to be using it for years and years, if they go years and years with really severe supine
Sure.
hypertension that's undetected, yeah, those are the guys that are going to die early of heart attacks and strokes. And
Yes,
so, you
30% of
know,
life right there.
exactly. So by universalizing the practice of ABPM studies in those patients, I think a lot of those guys are going to live longer for sure, because they get appropriately medicated. And then, you know, I do a lot of, you know, ordering echoes, stuff like that.
Yeah.
You know,
Yeah.
it's just internal medicine stuff, you know, and anytime, today on my live stream, I'm going to talk about a case of a guy that had an elevated creatinine, who was on, well, let me think, he was on dianabol, equipoise, and a very high dose of testosterone. And
You know,
he,
entry level stack. There's
yeah, right.
something guys call
And
that.
he started he was checking his labs by himself, okay, because his primary care doctor just told him, just get off the steroids, and I don't want to see you until you're off the steroids. Okay, but that's not very helpful.
Yeah.
Doctors really shouldn't be like that. But nevertheless, he was monitoring his own labs, and so as his creatinine started to rise, all his friends were like, hey man, just hydrate yourself, recheck them. And so he did it like 3 or 4 times, and his creatinine is like 2.1 when it was like half of that a year before. And he's well hydrated. His bicarb is like 17 or something, and his albumin is like 2.8. And so this guy sends me his labs. I'm like, you need to go to the hospital. You probably have very profound kidney damage. And it turns out that he did. He had almost nephrotic range proteinuria, and whether that was from the equipoise, the dianabol, or maybe even the testosterone, because in rare cases, testosterone can cause nephrotic syndrome. It doesn't matter. We caught it early enough that, you know, withdrawing all the compounds is shitty. And forgive me if I can't curse on this.
Yeah, you can say whatever the hell you want, dude.
As bad as that made him feel, you know, he ended up avoiding dialysis, you know,
Yeah.
so all his kidney numbers and stuff went back to normal. But, you know, my overall point is, if you're a guy who spends $40,000-$50,000 a year on gear, which a lot of these top tier guys do, you need to have a good doctor taking care of you. You need to pay money for a good doctor who's going to stay on top of you and frankly be a huge pain in the ass. You know, I'm not going to be there telling you what doses of things you can take and what you can't take. I mean, you're going to take whatever you take. All I ask you to do is just be upfront and tell me exactly what your plan is so that I can have a plan to know, when do we need to check your 24-hour ABPM? When do we need to start monitoring, your echoes and stuff? One thing I've run into recently is some of these guys have profound RV changes on their echoes. And so what that
Interesting.
suggests to me is a lot of them have very serious group 1 pulmonary hypertension. And how do we, what kind of risk reduction do we do in guys with what looks like severe pulmonary hypertension? Well, we do a lot of sleep studies on
Sleep
them because
studies. Yep.
we know
Yep.
that very serious sleep apnea can cause pulmonary hypertension, not group 1. I guess it would be technically I believe group 3, but obviously can worsen pulmonary hypertension. But a lot of the synthetic androgens themselves cause pulmonary hypertension. And so, medications that these guys are already using, like Cialis, tadalafil,
Yeah.
those have pulmonary vasodilatory properties. You just, to get that effect, you have to use much higher doses. And so a lot of my, PED users are on 40 milligrams of Cialis a day, and so having a doctor who's really knowledgeable about the compounds and how they affect the human body, especially if you're a guy who spends a lot of money on steroids, it's worth it to spend a few $1,000s a year just to have a very good doctor who's going to be on top of you. Because like I was saying at the beginning, steroid use, it's not safe, it's not guaranteed to kill you. It's somewhere in the middle. Where you lie on the spectrum of how dangerous it is depends largely on your genetics and your, individual picture. But what I believe plays the biggest difference is what kind of risk reduction do you do while you're on the compounds. And if you have a doctor that knows how to, optimize your risk as much as possible, you're giving yourself, I think, the best chance for, um, you know, living longer and getting out of your career. And the other thing about about the PED user guys, as you well know, you've probably seen them yourself. At every TRT clinic sees these guys because
Oh, absolutely.
when they're at retirement, what happens? They have to go on TRT. Okay, so they just become TRT patients as they get older. Well, it turns out that transitioning guys from, 3 grams of testosterone a week down to 200 milligrams,
It's a
that can
drop
be a
off.
little bit of a
It's a hell of a
challenge.
drop off.
That can be a very big challenge. And so having a specialist who knows who's done that transition before, who has protocols for doing that, can be very, very helpful. Because what happens a lot of the times is, they're on their own. They're getting advice off forums. They're getting
Yep.
advice from coaches, whatever, wherever they're getting their advice from. There, it's usually a non-medical person. It's not like a physician or like a nurse practitioner or PA, whatever. It's usually they're just doing it themselves, right? And that's not the best situation. What you want to do is go to a guy who, knows how to taper those guys off. So I do even have videos in my content about stuff like that, and or what's called post-cycle therapy. And
Sure.
yeah, it's all a risk reduction thing. At my clinic, I don't know about you guys, there are a lot of online TRT clinics that will
Too many, man.
prescribe.
Too many.
Yeah, they're for sure there's too many, and they're not very good, but a lot of them will prescribe synthetic androgens. So you have these clinics prescribing nandrolone, anavar, stuff like that. And, you know, I don't have, morally, that's fine for if people want to take anavar. I don't, obviously, that's
Yeah,
their
it's your
body,
body.
their
Do whatever the
life.
fuck you want, pretty much.
Yeah, yeah. So okay, that's fine. My issue is our clinic, we don't prescribe any synthetic androgens because our viewpoint, our perspective
Yeah.
is we're fine having patients on synthetic androgens. We love taking care of those guys and women too, but we don't encourage the use of those compounds. You know what
No.
I mean? We're all about risk reduction and how to keep people safe. So I don't prescribe stuff like that outside of research settings. And do I have plans to do pilot research studies on various assays? Absolutely, yes, I do. But a lot of my focus, I think, for the next decade is going to be number one on enhancing the care of just regular testosterone replacement in men and trying to transition it to a place that is more like postmenopausal hormone replacement in women, where we stop worrying so much about the serum levels and we start focusing a lot more on the body composition and the symptoms. Okay, because if you go to an expert menopause clinician and you're a woman who's on estrogen, you have hot flashes, maybe cognitive symptoms, when you follow up with that provider, they're not like, what is your estradiol level? We really
Yeah,
need
they don't
to,
care. They're not worried about
it's
that.
not about like, oh man, we got to keep your estradiol level under 100 or under 120 and make sure your progesterone level is at least 10. No, they go based on symptoms. They go, how are your hot flashes? Are they better? Are they worse? Are they no different? A lot of them, we aim for 80% improvement in symptoms. That's how you know you get a good dose of estrogen. Okay. And so I'm trying to move the TRT space more in that area. Okay. And make it not so like we got to just make sure his levels never go over 1,000 or 900 or 800 or whatever the arbitrary, cutoff point may be. And one problem with that is like, what is the long-term risk? We don't know. We don't know a lot about the long-term risks of most medications that we give. And when it comes to testosterone, there's a lot of long-term unknown risk because a lot of safety studies are just happening now in the last decade or so. So we had the Traverse trial, which even lay patients have heard about. Oh, the Traverse trial
Hmm.
proved testosterone is totally safe. Well, the Traverse trial is just about low doses of androgel.
Yeah, gel.
Like that, the findings from that trial apply to almost no modern TRT patients. And so there is a degree of long-term risk that we don't know about. But to me, it's always about individualizing the treatment and seeing, do we have someone who, regardless of their total testosterone levels, can they benefit from testosterone? And if we decide that they can and we put them on testosterone, we're looking for those benefits. So if you're massively obese and you have a lot of visceral fat, I care way more about what's happening to your skeletal muscle mass, your body fat, and in particular, your visceral fat while you're on treatment, and not so much about, oh man, we got to make sure that we just keep his testosterone level at 1,000 or 900. Like,
Yeah, yeah.
that is not, I'm not saying I never check testosterone levels in men on treatment or anything like that, but that's what I'm more focused on. And also the other paradigm I'm trying to change is to stop the universal use of aromatase inhibitors. I think a lot of TRT providers have gotten a little wiser. I mean, maybe you've seen differently. But a lot of these clinics just prescribe it to everybody, no matter what.
Yeah, it's
And
just default setting is what you get, 1 milligram a
exactly,
week.
it's like Dr. Tom O'Connor says, it's McDonald's medicine. But the other problem is some of them use AIs based on estradiol levels, and
Which doesn't mean
estradiol
shit
levels
either.
in men are just so worthless. Like, you talk about how unreliable testosterone levels are, estradiol levels are even more so unreliable.
Yeah.
So you have these guys with the conception that, oh, if my estradiol level gets above 45, I need an AI or really bad things are going to happen. No, your estradiol level has to rise as your testosterone level rises. And that's how you're going to reduce your visceral fat mass. That's how you're going to protect yourself from the negative redox effects of testosterone. So it's a beautiful balance when you have high testosterone, high estradiol, that's, and no side
Hmm.
effects, and your lipids are improving, which, by the way, testosterone therapy after a year improves
It usually
lipids.
lowers it across the board. I
It
usually see
improves lipids.
reductions.
And why does it lower it? Well, I believe that's also an estradiol effect because definitely in women, the thing that lowers lipids long
Hmm.
term is estradiol.
Hmm.
So I believe it's the same thing in men. So estradiol helps you have better lipid control, helps you have lower visceral fat, probably plays a very significant role in the bone strengthening effects of
Oh, no
testosterone,
doubt.
which is something we know we don't know as much about as we know about, its effect on fat and muscle mass and things like that. And so for me, it's about, monitoring side effects, but looking for the effects of testosterone. Testosterone, when it works, is going to change your body composition. If you're on testosterone and your body fat is staying the exact same, and your visceral fat is not going down and your muscle mass is not going down, or even if you're on testosterone and you're losing fat, but you're also losing muscle, you're not on a good dose of testosterone. And obviously, lifestyle things play a role, absolutely.
No doubt.
So if you have terrible diet, you're not doing any resistance training, which every male patient, that's the other thing is all my new patients are told, you've never lifted weights before? Okay, well, you need to start. We need to connect you with a personal trainer that knows what they're doing. And, a lot of guys are old and have various injuries, rotator cuff. I have a terrible rotator cuff that, limits my range of motion doing certain things. But every guy that's on testosterone absolutely needs to be doing resistance training. You don't need to be doing 5 hours of cardio a week or walking on a desk treadmill, or I mean, if you want to do stuff like that, that's fine.
Sure.
But the key thing is you're on testosterone, you need to be doing resistance training, and
Yeah.
we need to see your body composition changing. We need to see the skeletal muscle increasing. We need to see the body fat going down. And after about a year of treatment, we need to start seeing your visceral fat going down. That's how we know we're golden. And if that happens for you at a total testosterone trough level of 600, usually it requires higher than that. But some people, that's great. I don't care if your testosterone level 600, if you feel great and your body composition is changing, that's your dose. Some people require higher doses. Some people have total testosterone levels that are significantly higher than that to get that effect. And so, like I said, it's individualized. This is an area of medicine that I think a lot of healthcare providers, as you well know, have just jumped into it because there's so much money in it. Every man and his grandfather wants to be
Yep.
on testosterone these days. And so there are a lot of unscrupulous people that have dived into the industry. Well, I don't even just want to say unscrupulous. Definitely there are unscrupulous people for sure. There's unscrupulous people anywhere. There's a lot of money to be made. But a lot of the healthcare providers are just totally unprepared for how to deal with and manage this because they're operating outside guidelines. Okay, so the traditional guidelines in the treatment of men with hypogonadism, those are written for non-experts, are not written for people like me. But they're operating outside those super strict guidelines, and so they make their own whatever arbitrary guidelines, and almost all the time they just miss, like, remember, testosterone is a drug. It has very specific effects. You need to look for those effects when the guys are on treatment. And before they go on treatment, you need to do an analysis like, what are this guy's symptoms? And yes, obesity and high body fat are symptoms that can be helped with testosterone. And what is the rationale for why we're using the testosterone? And, that's what we follow. So if we're using it for body recomposition purposes, it should be very obvious that the thing that matters more than anything, that is, to me, that's the thing that has to be monitored the closest. That's where you get the benefit. That's where you get the life prolonging effects.
What was the way that you like? Did you personally have personal experience with like low T yourself? Is that kind of what was a big segue for, to dig down that
So,
rabbit hole into it?
I've always been interested in androgens ever since I was a med student. It was my dream to become like an endocrinologist that worked with bodybuilders because I was like, I'm going to run this boutique, bodybuilders clinic out in Long Beach, California.
Sure.
But anyway, so I've always been very, very interested in androgens in general. But the thing that got me into it was just, had some mentors that I met in residency that did it and learned how to do it initially from them. But also, yes, when I was a resident, believe it or not, I started residency at 230 pounds. Okay. 3 years later, when I walked out the door at the University of Missouri, Mizzou University Hospital, I was 330 pounds.
Ugh,
Okay. And my total testosterone levels were like 200. So, personally, yeah, I got on testosterone therapy, and obviously now I'm nowhere near what I used to be.
no,
I don't,
obviously.
that's not all attributed to testosterone, but um but yeah, just dealing with that myself and going through that myself was really like, man, testosterone really can be a life-changing drug for a lot of
Oh, no
people.
doubt.
It's just, got to be done right. It's got to be done by an expert. It's got to be done by someone monitoring your body composition. Because like I said, if there's one key takeaway from this interview that I just want to get out is you have to follow body composition. You just have to. Like that's the effect you're looking for. That's what you need to follow. Even going back to when some of the synthetic androgens were first synthesized in the 1950s, what was their purpose? To treat muscle wasting,
Sure.
to treat burn patients with profound, muscle loss. So the androgen effect that you're looking for, whether it be from TRT doses of testosterone or synthetic androgens or whatever, is you're looking at what's it doing to the skeletal muscle mass. Okay. And older patients, we know that one of the biggest, most reliable predictors of longevity is your skeletal muscle mass
Muscle. Sure.
and your muscle strength as well. So testosterone improves muscle strength. And that's one thing I've been thinking about doing, is also testing grip strength in all patients. Maybe I should do it. It's so easy to do. But so muscle strength, so muscle mass and muscle strength in particular are very important for longevity. And then obviously the lower your visceral fat, the longer you'll live too. So that's another positive beneficial effect of testosterone. And surprisingly enough, it's not really your subcutaneous fat, because there's something that I talk about in my book that's coming out late this fall, early this winter, where I
Hmm.
delve into the body recomposition effects of testosterone, and I talk about something called the obesity paradox. So it turns out that patients with certain chronic diseases, chronic kidney disease, coronary artery disease, heart failure, even just frail elderly patients, it turns out that those patients who have higher body mass index tend to live significantly longer than patients with lower body mass index. And that confused a lot of researchers and a lot of media people reporting on the research that showed that. But it turns out that the fat mass part of the equation, it's not that those patients are fatter why they're living longer. It's that those patients tend to have lower amounts of visceral fat. They have a lot of subcutaneous fat, which
Sure.
subcutaneous fat actually has protective properties, believe it or not, and they have more muscle mass. So really what the obesity paradox is about is when in the context of chronic disease, so profound systemic inflammation, the degree to which the underlying inflammatory process causes you to break down a lot of your skeletal muscle, that's a surrogate marker for longevity. So the patients that are sickest with chronic disease are the patients with the most underlying inflammation, which causes sarcopenia, cachexia, sarcopenia,
Yeah.
and you know uh, increases visceral fat. And those patients also have sometimes lower amounts of subcutaneous fat, but they may have lots of subcutaneous fat. So the 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 whole obesity paradox thing also plays into the testosterone story, in that yes, patients with chronic disease who are sarcopenic, those are also patients that should be considered for testosterone therapy,
Sure.
regardless of
Definitely.
what their testosterone levels are. Because by reversing the inflammatory process that's causing them to lose muscle, you may actually be giving them a longevity benefit. And there's all kinds of research right now. In fact, there was a paper published earlier this year. I need to look at what the journal was, that talked about sarcopenia. And the researchers in this paper were lamenting the fact that they didn't have a novel drug available to treat sarcopenia. And they made the comment that testosterone's so effective for sarcopenia. It's just unfortunate that we just don't have some kind of synthetic, massively expensive drug that would do the same things as testosterone with the same safety profile. And it's just like, well, if testosterone's effective and safe, why don't you just use testosterone? You
Too
know,
cheap, man.
it is funny reading papers like that. I mean, sad, but also funny because the answer is staring us right in the face. Testosterone is absolutely not just for people with low testosterone levels. Testosterone is for people who can benefit from the effects of testosterone without excess, undue long-term risk to their health. And there's a lot of patients that meet that criteria that are told by their primary care doctors or even some of these TRT clinics, sorry, we can't treat you because your levels are too high. And it ignores all the signs and symptoms that they may have, and even some of the chronic diseases they may have that could greatly benefit from testosterone. So that's really where my expertise and where I'm trying to change those paradigms is more looking at testosterone as a drug and looking for the drug effects of the drug. We don't put people on like Prozac for depression and then have them come back in 3 months and be like, we need to measure a serum
A
Prozac level.
serum, sure, yeah,
Like, you know what I mean? So I think because testosterone is a hormone, we have reference ranges for what healthy people should have in terms of their natural endogenous levels. We've got it in our head that you can never have levels that are over that limit, otherwise only bad things happen. I've had patients tell me, Doc, I'd literally be dead than go back to how I was
hell
feeling
yeah,
when I was on testosterone. I would rather be in the ground.
yep.
And I believe when they say that, they're dead serious about that. I
Hmm.
believe they're absolutely dead serious. So in a patient like that, I'm not going to hyper obsess about their testosterone levels if they're at a dose that makes them feel good and all their other health parameters are good. And, I do a lot of coronary artery calcium
And
scans
they're
of
only,
just
dude, they're only $50. At
say,
least here, they're $50. I mean, why
exactly.
not?
They're $50 here too.
It takes 5
75 if
minutes.
you want a full vascular screening, like a AAA ultrasound, stuff like that. And, if all that stuff is good and we're monitoring the patients really closely, those
Yeah,
patients, they don't give a shit. They're like, they're good. They're happy. They want to be left alone. They don't want someone who's just going to look at their numbers and treat them based on their testosterone level numbers. They want to look at what real outcomes are, that actually matter to them. These guys don't want to get older and be super frail and be walking around with a cane in their 70s with, really profound sarcopenia. Which I'm not saying that happens to everybody who's not on testosterone, don't get me
sure.
wrong. But these guys' functional status is very, very important to them. And I feel like as a physician, and I do feel like I'm a pretty, talented physician. To me, this is my life's passion. This is what I've spent. I sacrificed my entire 20s and most of my 30s learning how to do this. And it's very, very important to me that I take a nuanced approach to everybody and look at not only what their symptoms are and what I can improve, disease wise, but also how I can do that in a way that aligns with their values. If function as you get older is most important to you, then that's what needs to be important to me as well. If taking the least amount of risk and keeping everything in the normal range is what's important to you, then that's what's important to me in your specific case. So it's all about individualizing the treatment. A lot of and
Absolutely.
you could tell me if you've had a different experience, but from what I've seen, a lot of these TRT clinics are just algorithm followers. If the
It
patient
is.
has X
Hmm.
level, do this. If they have X level, give them that. Stuff like that. And I'm not an algorithm follower. Everybody's very, very different. Everybody has a different risk profile and a different risk tolerance. And I think an expert clinician will take all of those things into account when they decide how they're going to treat you, how they're going to monitor you.
When it comes to actually implementing testosterone, do you stick with injections? You stick with transdermals? What is your experience like? What have you found more efficacious in your certain circumstances?
So, I'm TikTok. I have a testosterone TRT tier list. So I think injectable testosterone is still the king. I really do. I think the best way to do it is sub-Q.
Easy to
Um,
manipulate, very easy to manipulate.
Easy, yeah, it is, and low amounts of side effects. And I think the most proven benefits are just with the injectable. They're releasing all different kinds of new formulations. Like we got the Natesto nasal gel, we got a variety of oral stuff, even compounded oral
Yeah, like
stuff.
Jatenzo, the undecanoates and all that.
Yep, Tenzo. And I think just, the current evidence is that the injectables are just king. I think you get the best symptom relief, you get the best body composition effect, you get the best delivery of the testosterone to the brain through the injectables. And I think, the way that you can really stabilize someone's levels and make it really smooth with low amounts of side effects is microdosing sub-Q test E or test C. I just and also, as you know, that's the cheapest way to do it. So for me, that's still the king. Maybe they'll invent some kind of special pellet that is physiologic and releases testosterone the exact same way your testes do in a pulsatile fashion. And maybe
It'll
they'll
be,
invent, maybe
$10,000 a
maybe
year.
yeah, maybe they'll invent that kind of product, and that will, supplant the injectables, but I just don't see that happening anytime soon. So for me, it's just still the injectables.
Any information how people can like contact you?
Yeah, so b3clinic.com. We just changed the company, so we're in the process of building a new website, but there's a patient form on there that you can fill out, and we can potentially see you if you're in our area where we have, where we can see people. But if you're not, then we ask you, can we forward you to another competent, TRT provider? And if you say yes, then usually we send them to people like you guys. We just, so someone comes in who's in Tennessee who can't see me, that'd be someone I potentially, would send to you. So, yeah, so b3clinic.com. I'm also on TikTok at cbronsmd, CBRONS MD. And now we're doing daily videos and live streams. And
Mhm.
uh, it's been fun educating the general public. And there are a lot of healthcare providers that follow me too. So I think even they're learning something, which is great.
Awesome, man. Awesome. Well, I appreciate you joining us today, sir. That
Thank
will
you.
be
Thanks for having me.